in terms of the acute stroke unit or cohort units, in your stages of rehab, that would be subsumed under hyperacute, I would assume. And further to that is, have you heard from other provinces about how cohorting is going? There's a lot of sort of emphasis being put on the gold standard of acute stroke units, but the reality of it is, especially in this province with our history of rehab, is that we will have to probably go more often with cohorting than acute stroke units. So I'd be interested if you have information about how it's been going in other health authorities outside of BC about that.
Yeah, hi. Yeah, so definitely the acute stroke unit would be considered the hyperacute stage. Although in many places there's a combination of the acute stroke rehab as well as the sort of progression onto an inpatient rehab, and it actually takes place essentially on the same floor. In terms of how it's going in other provinces, I know that Ontario is probably more further ahead in terms of actually having more organized stroke units per se that are dedicated, and you're quite correct, the push is to cohort. There is some discussion that cohorting is not the same as having an actual stroke rehab unit. I think generally the idea is that if they are in a dedicated geographic area with a dedicated team, that you can then build on the expertise, their efficiencies in terms of communication and delivery of therapies, and that's where a lot of the advantages are. So there is still a push definitely to at least cohort, if not having a true stroke unit per se. So hopefully that answers your question.
How about Kootenay Lake in Nelson? Anybody there?
Yes, there's 10 of us here. And
wow.
I'd like if you could define cohorting for me.
I don't know if I have the official definition, but cohorting is really referring to the geographic grouping of stroke patients so that they are actually located on one ward unit or floor or area. So that's what most people mean when they talk about cohorting.
Okay, we'll move on to Penticton. Anybody in Penticton?
Yes, we've got 12 and we've got 2 questions.
Go for it.
Hi, Diane. It's Lori Seeley. With the ACVS strategy, we've been really focusing a lot on getting the sites to endorse their site designations. So, Jennifer, are you seeing as a priority with this moving forward, once you get the ministry to agree to it, that would be one of the first priorities, or where do you think this will start? Because we could get some of the ball rolling now.
I think it's great that if the acute definitions can be agreed upon first, and then we can then look at the rehab designation. I think, in our discussions with the ACVS team, what they're really actually hoping from us is some more practical implementation strategies for the acute stroke facilities first, so that they can actually implement it directly into their particular pathways or guidelines. So we certainly will be looking at that. So we'll have to discuss further about how much of a priority is it for us to then have actual facility designations pinned down within a certain period of time. So that's still up for discussion.
Thanks.
And second question. Hi, this is from Bev Bowden, and I'm just wondering in regard to the definition of level 3, a primary stroke rehab, could you please identify what all disciplines that you would see involved in that level of expertise?
Sure, so let me go back to level 3. So level 3 would likely have the core rehab team, meaning physiotherapy, occupational therapy, and possibly speech and language, although it may not be on a full-time or consistent basis, and then social work. So that's what I would tend to expect from that level of care. And again, it's not dedicated to stroke per se, so they would serve not just a stroke population.
And would there be a physiatrist on site, and would there be designated rehab nurses, as in their qualification for rehab nurses?
In terms of the physiatry access, of course, there are limited physiatrists in the province. So we didn't specify that you must have a physiatrist, but certainly one of the things we're looking at is to be able to provide some teleconsulting services for physiatry, to provide at least some of that oversight. In terms of nursing care, we actually didn't talk about specific rehab nurse training. However, if you have a rehab unit, even if it's a generalized one, then I would expect that those nurses would have more expertise in terms of that population, although again, not limited to stroke per se.